Hi everyone, welcome back to my YouTube channel. Today's video is about MedPAC's March 2022 report to Congress on the Medicare Advantage and Medicare prescription drug programs. Let's dive right in. In 2021, the Medicare Advantage program included 4,778 plan options offered by 186 organizations, enrolled nearly 27 million beneficiaries. 46% of Medicare beneficiaries with both Part A and Part B coverage, and paid Medicare Advantage plans an estimated $350 billion, not including Part D drug plan payments. The Commission strongly supports the inclusion of private plans in the Medicare program. Beneficiaries should be able to choose among Medicare coverage options, including the traditional fee-for-service Medicare program and the alternative delivery systems that private plans provide. Because Medicare pays private plans a predetermined rate, risk-adjusted per enrollee rather than a per-service rate, plans have greater incentives than fee-for-service providers to innovate and use care management techniques to deliver more efficient care. Policymakers have been concerned that the disruption in service utilization and plan administrative activities related to the coronavirus pandemic could impact payments in unexpected ways. However, because Medicare payments to Medicare Advantage plans are established before the start of each calendar year based on prior year's data, overall plan revenues in 2020 remained at pre-pandemic levels while service use declined, resulting in increased profitability for most Medicare Advantage plans. Although utilization remained below pre-pandemic levels and most publicly traded insurers reported profitability in 2021, some plans are concerned that lower utilization in 2020 limited their ability to document diagnoses, resulting in smaller risk adjustments and lower plan revenues in 2021. The effect of risk adjustments on 2021 revenues is not yet known and likely varies across the industry. In 2022, Medicare payments to Medicare Advantage plans are increased because of the expectation that deferred care will raise utilization above pre-pandemic levels. MedPAC does not anticipate that the pandemic will have a deleterious impact on overall plan revenues. Medicare Advantage plans continue to capitalize on their administrative flexibility and reduce their relative growth in healthcare costs year over year. For 2022, the average plan bid to provide Medicare Part A and Part B benefits was 15% less than fee-for-service Medicare would spend for those enrollees, and nearly all plan bids are below the cost of fee-for-service Medicare. However, these efficiencies are shared exclusively by the companies sponsoring Medicare Advantage plans and Medicare Advantage enrollees in the form of extra benefits. The taxpayers and Medicare beneficiaries who fund the Medicare Advantage program do not realize any savings from Medicare Advantage plan efficiencies. Instead, Medicare spends 4% more on Medicare Advantage than it would spend on fee-for-service Medicare. The Medicare Advantage program has been expected to reduce Medicare spending since its inception. Under the original incorporation of private plans in Medicare in 1985, payments to private plans were set at 95% of fee-for-service payments. However, private plans in the aggregate have never produced savings for Medicare due to policies governing payment rates to Medicare Advantage plans that the Commission has found to be deeply flawed. In particular, coding intensity inflates payments to Medicare Advantage plans and undermines plan incentives to improve quality and reduce costs. The Quality Bonus Program boosts plan payments for nearly all enrollees but does not meaningfully reflect plan quality from the perspective of the Medicare Advantage plan enrollee or the Medicare program, and plan benchmarks are set high enough that the government subsidizes substantial and ever higher levels of extra benefits for Medicare Advantage enrollees. Apart from payments, the Commission finds that the plan submitted data about beneficiaries' healthcare encounters are incomplete, preventing policymakers from understanding plan efficiencies or implementing program oversight. These policy flaws diminish the integrity of the program and generate waste from beneficiary premiums and taxpayer funds. A major overhaul of Medicare Advantage policies is therefore urgently needed. Over the past few years, the Commission has made recommendations to address coding intensity, improve the completeness of encounter data, replace the quality bonus program, and establish more equitable benchmarks. The Commission remains committed to including private plans in the Medicare program. Beneficiaries clearly find Medicare Advantage to be an attractive option through which to receive their Medicare benefits, as evidenced by robust trends in year-over-year enrollment growth. However, this does not mean that Medicare should continue to overpay Medicare Advantage plans. In fact, under current policies, as Medicare Advantage enrollment continues to grow, doing so will further worsen Medicare's fiscal sustainability. It is therefore imperative that the Congress and the Secretary make policy improvements. To encourage efficiency and innovation, Medicare Advantage plans need to face appropriate financial pressure similar to what the Commission recommends for providers in the traditional fee-for-service program. Enrollment. For the third consecutive year, enrollment in Medicare Advantage plans grew by 10%. Between July of 2020 and July of 2021, Medicare Advantage enrollment grew by 2.5 million enrollees to 26.9 million enrollees. In 2021, about 46% of Medicare Advantage eligible beneficiaries were enrolled in Medicare Advantage plans, up from 43% in 2020. Plan availability. In 2022, access to Medicare Advantage plans remains high, with 99% of Medicare beneficiaries having access to at least one plan. The average beneficiary has 36 available plans sponsored by 8 different parent organizations, both of which are increases relative to 2021. Plan rebates. In 2022, rebates that are used to provide additional benefits to enrollees are at a historic high of $164 per enrollee per month. The average total rebates are 17% higher than in 2020, $24 higher per enrollee per month. Plans can devote the rebate to lower cost sharing, lower premiums, or supplemental benefits. In 2022, 43% of projected plan rebates was allocated for lower cost sharing, down from 46% in 2021. Plan payments. In 2022, plan payments remain higher than fee-for-service spending levels. Total Medicare payments to Medicare Advantage plans average an estimated 104% of fee-for-service spending. The 2022 estimate incorporates about 3.6 percentage points of uncorrected coding intensity. Relative to fee-for-service spending for Part A and Part B benefits, quality bonuses in Medicare Advantage account for 3 percentage points of Medicare Advantage payments. Using plan bid data for 2022 and ignoring the impact of coding intensity, MedPAC estimates that Medicare Advantage payments are 100% of fee-for-service spending. In addition, Medicare Advantage benchmarks the maximum amount Medicare will pay and Medicare Advantage plan to provide Part A and Part B benefits continue to be well above fee-for-service spending levels. In 2022, Medicare Advantage benchmarks averaged an estimated 108% of fee-for-service spending, including quality bonuses, about the same level as in 2021. Bids fell to 85% of fee-for-service, a record low. Risk adjustment and coding intensity. Medicare payments to Medicare Advantage plans are enrollee specific based on a plan's payment rate and an enrollee's risk score. Risk scores account for differences in expected medical expenditures and are based in part on diagnoses that providers code. Medicare Advantage plans have a financial incentive to ensure that their providers record all possible diagnoses. Each diagnosis documented raises an enrollee's risk score, and higher enrollee risk scores result in higher payments to the plan. A commission analysis of 2020 data shows that higher diagnosis coding intensity resulted in Medicare Advantage risk scores that were about 9.5% higher than scores for similar fee-for-service beneficiaries. By law, CMS makes an across-the-board reduction to Medicare Advantage risk scores to make them more consistent with fee-for-service coding, and although CMS has the authority to impose a larger reduction than the minimum required by law, the agency has never done so. In 2020, the adjustment reduced Medicare Advantage risk scores by 5.9%, resulting in Medicare Advantage risk scores that were about 3.6% higher than they would have been if Medicare Advantage enrollees had been treated in fee-for-service Medicare, translating to $12 billion in access payments to Medicare Advantage plans. MedPAC continues to find that coding intensity varies significantly across Medicare Advantage plans and that increasing diagnostic coding allows some plans to offer more extra benefits, thereby attracting more enrollees and undermining the goal of plan competition based on improved quality and reduced healthcare costs. The Commission previously recommended changes to Medicare Advantage risk adjustment that exclude diagnoses collected from health risk assessments, use 2 years of diagnostic data, and apply an adjustment to eliminate any residual impact of coding intensity. These changes were intended to improve equity across plans and eliminate the impact of differences between Medicare Advantage and fee-for-service coding intensity. Recent reports from the Office of Inspector General highlight the impact of Medicare Advantage plans' use of medical chart reviews, a coding practice that does not exist in fee-for-service Medicare, and of health risk assessments to increase risk scores. The Commission finds that nearly 2/3 of Medicare Advantage coding intensity could be due to chart reviews and health risk assessments, and that these two mechanisms are a primary factor driving coding differences among Medicare Advantage plans. Quality in Medicare Advantage. The current state of quality reporting in Medicare Advantage is such that the Commission can no longer provide an accurate description of the quality of care in Medicare Advantage. With 46% of eligible Medicare beneficiaries enrolled in Medicare Advantage plans, good information on the quality of care that Medicare Advantage enrollees receive and how their quality compares with quality in fee-for-service Medicare is necessary for beneficiaries and policymakers to have the ability to compare Medicare Advantage and fee-for-service quality and to compare quality among Medicare Advantage plans. In its June 2020 report, the Commission recommended a new value incentive program for Medicare Advantage that would replace the current quality bonus program. Mandated report comparing the performance of DSNPs or dual eligible special needs plans and other plans that serve dual eligible beneficiaries. Dual eligible special needs plans or DSNPs are specialized Medicare Advantage plans that limit their enrollment to beneficiaries who receive both Medicare and Medicaid. The Balanced Budget Act of 2018 permanently authorized DSNPs and starting in 2021 requires them to meet new standards for integrating the delivery of Medicare and Medicaid services. The Commission is mandated by the Balanced Budget Act of 2018 to periodically compare the performance of different types of DSNPs and other plans that serve dual eligible beneficiaries. The Commission finds that the performance data that Medicare Advantage plans report as part of the Healthcare Effectiveness Data and Information Set or HEDIS provide limited insight on the relative performance of DSNPs. This finding is consistent with previous Commission analyses that have examined the difficulties of assessing the quality and performance of Medicare Advantage plans. The Medicare Prescription Drug Program or Part D Status Report. In 2021, Part D paid for outpatient prescription drug coverage on behalf of more than 49 million Medicare beneficiaries. For Part D plan enrollees, Medicare subsidizes about 3/4 of the cost of basic benefits. Part D also includes a low-income subsidy or LIS that provides assistance with premiums and cost sharing to about 13 million individuals with low income and assets. The 2020 and 2021 benefit years were extraordinary due to the coronavirus pandemic and its toll on Medicare beneficiaries and healthcare providers. However, Medicare beneficiaries experienced comparatively less disruption in access to medicines than in access to other types of healthcare services. In 2020, Part D program expenditures totaled $105.3 billion, accounting for about 11% of Medicare spending. Of that amount, enrollees paid $13.6 billion in plan premiums for basic benefits. Above and beyond program spending, Part D plan enrollees paid $17.6 billion in cost sharing plus additional amounts in premiums for enhanced benefits. Since its inception in 2006, Part D has changed in important ways. Enrollment has moved gradually toward Medicare Advantage prescription drug plans or MAPDs that provide combined medical and drug coverage. In absolute numbers, enrollment in standalone prescription drug plans or PDPs began to decline in 2019. In 2021, Part D enrollees were split evenly between PDPs and Medicare Advantage prescription drug plans. Prescription drug use and spending have also changed dramatically. Part D enrollees have greatly expanded their use of generics, while a relatively small percentage of prescriptions for high-cost biological products and specialty medications accounts for a mounting share of spending. Medicare's payments to Part D plans have changed as well. Whereas fixed dollar payments per enrollee used to make up most of Part D's subsidies, over time, a growing share has taken the form of cost-based reimbursements to plans through Medicare's reinsurance. The financial risk that plans bear, as well as their incentives to control costs, has declined markedly. In 2020, the Commission recommended major changes to the Part D benefit design and Medicare subsidies to restore the role of risk-based, capitated payments that was present at the start of the program and provide some drag on drug price increases. Nearly 300 organizations sponsor Part D plans, but most beneficiaries are enrolled in plans sponsored by a handful of large health insurers. Formularies remain plan sponsors' most important tool for managing drug benefits. Generally, pharmaceutical manufacturers pay larger rebates when a sponsor positions a drug on its formulary in a way that increases the likelihood of winning market share over competing drugs. Plan sponsors also use provisions in network contracts with pharmacies that require post-sale recoupments or payments for meeting performance metrics. Plan sponsors and pharmacy benefit managers or PBMs have negotiated rebates and pharmacy fees that have grown as a share of Part D spending. Enrollment in 2020 and benefit offerings for 2021. Between 2020 and 2021, enrollment in prescription drug plans declined from 25.5 million to 24 million, while enrollment in Medicare Advantage prescription drug plans grew from 21.9 million to 24.3 million. As a result, in 2021, just over 50% of enrollees were in Medicare Advantage prescription drug plans compared with 30% in 2007. The number of enrollees who receive the LIS has grown more slowly than the broader Part D population. In 2021, LIS enrollees made up 27% of total enrollment compared with 39% in 2007. For 2022, beneficiaries continue to have a broad choice of plans, with growth in Medicare Advantage prescription drug plans more than offsetting a contraction in the number of prescription drug plans or PDPs. Compared with 2021, sponsors are offering 7% more Medicare Advantage prescription drug plans open to all beneficiaries and 19% more MAPDs tailored to specific populations, special needs plans, but 23% fewer prescription drug plans or PDPs due primarily to mergers among plan sponsors. In 2022, 2,159 plans are participating in the Center for Medicare and Medicaid Innovations Part D Senior Savings Model that covers certain insulins at cost sharing of no more than $35 per 1 month supply. Most Part D plans use a 5-tier formulary with differential cost sharing between preferred and non-preferred drugs, as well as a specialty tier for high-cost drugs. For 2022, the base beneficiary premium rose by less than 1% over 2021 to $33.37, reflecting the relatively small increase in the total average estimated cost for basic benefits after taking post-sale rebates and discounts into account. However, individual plans' premiums vary substantially. In 2022, 198 premium-free prescription drug plans or PDPs are available to enrollees who receive the low-income subsidy, a 24% drop from 2021. All regions have at least 4 premium-free prescription drug plans for LIS enrollees. Part D program costs. Between 2007 and 2020, Part D program spending increased from $46.2 billion to $91.7 billion, which amounts to average annual growth of 5.5%. Medicare's reinsurance, which covers 80% of spending in the catastrophic phase of the benefit after rebates, continues to be both the largest and fastest growing component of program spending at an annual average rate of about 15% since 2007. As a result, between 2007 and 2020, the portion of the average basic benefits paid to plans through the capitated direct subsidy plummeted from 54.7% to 13.5%. In 2020, fewer enrollees reached the benefits catastrophic phase due in large part to a statutory increase in the out-of-pocket threshold. High-cost enrollees, those whose spending reaches the benefits catastrophic phase, accounted for 62% of Part D spending, up from about 40% before 2011. In 2020, average prices continued to grow more slowly than in prior years, owing to the decline in prices of generic drugs. However, generic share of prescriptions plateaued at about 90% in 2017, and further opportunities for generic substitution may be limited because a significant portion of brand products are protected from competition through longer periods of market exclusivity, extensive patent protection, or both. Inflation in prices for brand name drugs and biologics will likely continue to drive spending upward. In 2020, over 443,000 enrollees filled a prescription for which a single claim was sufficient to meet the out-of-pocket threshold, up from just 33,000 in 2010. Beneficiary access and quality in Part D. Data from CMS audits and Part D appeals processes suggest that beneficiaries may be less likely to encounter access issues for most drugs than in previous years. However, among beneficiaries without the LIS or low-income subsidy, high cost sharing for expensive therapies may be a barrier to access. For 2022, average star ratings for Part D plans increased substantially, but much of that increase reflects changes CMS made in how it calculated the ratings to address the coronavirus pandemic. While average star ratings for Medicare Advantage prescription drug plans continue to exceed those of prescription drug plans, the trend among Medicare Advantage PD sponsors of consolidating contracts leads them to question the validity of Medicare Advantage PD ratings. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.